I want to say thank you to Fiona Sim, who has acted as a kind of advisor over many, many weeks of these talk series, but in particular for this invitation, for arranging this invitation, because Sherry Glied is a colleague of hers, and she knows her well. Most recently, the two of them have been co-commentators on the Israeli Journal of Public Health Research, a series of articles that covered the international aspects of the COVID-19 pandemic. And the two of them, their two articles were amongst the most erudite and clearly presented articles of the whole series. And it's a real privilege to have somebody who's able to give that concise overview and to explain things as clearly talking to us tonight. So, Sherry, please.
Thank you very much, and I'm delighted to be there virtually. I wish I were actually there in person. It would be a great deal more fun, but I'll try to make up for it. And what I'm going to do is talk today. Let me see if I can get all the Zoom things going. Is that all set? Do you see it correctly?
Right.
I'm going to speak today about what lessons have we learned about how the U.S. healthcare system works in the way it has responded to the COVID-19 pandemic. And I want to be very clear that I'm going to talk about the healthcare system and not the public health system. I actually could talk about the public health system probably till I was blue in the face because it has been so catastrophic. But I thought that for today, I would talk a little bit more about the healthcare system. And maybe another time we could talk about how our two countries have responded on the public health front. I think both with some notable successes and with some very dismal failures. So the overall topic here is we are in a new stage of the US healthcare system after the passage of the Affordable Care Act in 2010 and its implementation in 2014. The structure of the US healthcare system actually has taken a somewhat different form. And it's within that context that I thought I would talk a little bit about what we've learned, what COVID-19 has exposed or otherwise in the system. And I'm going to talk about 4 dimensions of it. I think the easiest way, if you have questions, is for me to take questions at the end of each one of these sections because they're a little bit distinct from one another. And I'm going to start off talking about coverage. If you have had any connection to the US healthcare system, thought about it at all, you know that coverage has long been the great shame of the US healthcare system. The fact that substantial numbers of Americans have not had health insurance coverage, that there is a large literature on the consequences of ill health on bankruptcy in the United States, as well as people who cannot access services because they don't have coverage, has been sort of the centerpiece of the way people have looked at the US healthcare system historically. But now we're in this new era, and it might be worth rethinking about how we imagine it in this new era. So I want to start off with a picture of how the US healthcare system looks today. And I will say I was thinking about Tolstoy. You know, all healthcare systems are very confusing, but the US healthcare system is much more confusing than any other healthcare system. Having looked at several different healthcare systems, I think they all are almost incomprehensible to people who have not actually experienced them. Fiona and I are both on an advisory board for the Brookdale Center in Israel, and every time we go, I learn something about the Israeli healthcare system I find absolutely shocking. Although I've been going for 15 years now, the American healthcare system has just even more of those bizarre, shocking features than anyone else. But here's one way to think about how it is structured. So we have 2 kinds of health insurance, public and private. Those are very capacious categories. There are more than 2 different public insurance programs that address different populations. There are many, many different private insurance programs that address different populations. So these are just broad categorizations, and they also vary considerably by age group. I'll show you that in another slide as well. But what you can see here is that People 65 and over in the United States are virtually all covered by public insurance. They're covered by a program called Medicare, Care for the Elderly. Children under 19, about a third of them are publicly insured, and most of the rest are privately insured. The ones who are publicly insured are insured under a program called Medicaid, Aid for the Poor. So they are low-income children who are covered by the Medicaid program. And you can see there's a small red section there. It's pretty small. Those are uninsured children under 19, virtually all of whom are eligible for some kind of health insurance program, but have not enrolled in it. And then you have the population 19 to 64, the vast majority of whom are privately insured, but there is a segment within that population that is publicly insured. Most of those would be on the Medicaid program. Some of them would be on the Medicare program. And you can also see that there's a large swath of people who are uninsured. It is actually impossible to compare statistics about insurance coverage across countries, because countries that have universal health insurance, like Britain, don't collect data on whether people have health insurance or not. It would be a sort of bizarre question to ask. But one of the things that makes the US look particularly bad is that we do ask that question, and we ask that question of everyone who is in the United States on the day we put out the survey. So it is important to note that about a quarter of the people in that red block are actually non-citizens and not legally eligible for public insurance. That only covers a quarter of them, but it is a difference in the way we measure the statistics. Importantly, in thinking about COVID, however, is the blue section and how to think about that. And the key element of the blue section is that almost all private health insurance coverage in the United States is job-based. People get their health insurance through employment. Typically, if you lose your job, you're eligible to retain your employer-sponsored coverage for a period of time afterwards, although you have to pay extra for it, quite a lot extra for it. But a great deal of the coverage is job-based. As you move between jobs, this can be problematic. And the final piece of this puzzle, this is really not doing justice to the complete absurdity of the structure of the US healthcare system, but the green bar in the 19 to 64 category, most of the people in there are covered under the Medicaid program. The Medicaid program is administered by the states, not by the federal government. And the states have an option about who they want to cover under that program within federal constraints. And at this point, about 13 of the states have chosen not to expand that program to capture all low-income people. The federal government pays most of the cost of such an expansion, but some of the states are ornery. I believe that is the word that you would need to use here, and have decided that, notwithstanding that they would not need to put a lot of their own money down, they just don't like the idea, and they are not going to cover people who are low income under this program, except for certain defined groups, what people used to call the deserving poor, mothers, children, and so on, the disabled, but not able-bodied, in principle, men and women. So in many of those states, if you're a man or a woman especially if you don't have children, no matter how low your income is, you're not eligible for any public health insurance. And that is the Medicaid state option picture. Another way of looking at more or less the same data is this information from the National Center for Health Statistics, the most recent survey before COVID of how many people were uninsured. And you can see in this top bar here that the overall uninsurance rate was running at about 10.3%. It was highest for that population 19 to 64. Almost all of the elderly 65 and over are covered. Those who are not are typically people who are not American legal residents, and that's why they're still in there, even though that is a universal program for people 65 and over. But because of the way we count, we do have uninsured people in that category. And there are not that many uninsured children because we have, over several decades now, aggressively expanded public programs to try to capture most of those children. So the largest group of uninsured people are those who are in this 18 to 64 category. And recall, they are extremely dependent on job-based coverage. So when COVID hit, this is what happened to the number of people with jobs. You can see this is March of 2020, and it just fell off a cliff by about 10 percentage points, the share of the population who were working. And those of us who worked in health insurance were very concerned that what would happen now is that all these people would lose their job-based coverage and become either financially impoverished and unable to afford healthcare because they had no more health insurance, or potentially even worse, that they would not ever seek any care. They might actually develop COVID, they might infect others, they wouldn't get tested. And so there was a lot of concern that this enormous drop in employment would really be devastating in terms of health insurance coverage. On the flip side of this, and of course, this was all happening in the midst of the presidential primaries for the Democratic Party. So politics always plays a part in everything. The Democratic candidates were debating universal coverage, and I think there was a feeling among some people that this would be the catastrophe that would finally bring the United States to a more rational healthcare system, a more coherent healthcare system, because all these people were going to lose health insurance. So everyone was kind of agreed that everyone would lose health insurance, and some people were more unhappy about it, and others saw it as possibly a spark that would bring a better future response. Now, the federal government saw all of this happening, and at that point, Donald Trump was president. He was not really, as my kids would say, into COVID. So he was trying to minimize the way that you might think about this. And the policy responses were consequently, especially around the uninsured, fairly anemic. States that had already fully signed on to the expansions that the Obama Affordable Care Act brought forward, those Medicaid expansions, they were able to enroll their uninsured populations in this extended coverage. But the federal government, which could have done many things in terms of expanding coverage at this point in time, did nothing. It decided that they were not going to expand, they were not going to step in and expand Medicaid in the states that had not expanded Medicaid. They were not going to reopen the marketplaces. They were just going to leave things as they were. Instead, what they did is put in place measures to protect providers who might otherwise have incurred uncompensated costs by treating people with COVID. And they also promised to pay for testing for uninsured people. And the coverage for treatment for COVID patients, it was promised that if COVID patients were, if somebody was admitted to the hospital and it turned out that they had COVID, the federal government would pay their bill if they were uninsured. Of course, from a public health standpoint, since a patient might not know whether she or he had COVID, the consequence of this rule for whether somebody would go to the hospital or not might not be very desirable. If you were afraid that what you had was not COVID, you might choose not to go to the hospitals to avoid incurring the financial consequences of that, which would not be protected if it turned out that you didn't have COVID. So things looked pretty ugly in many ways going into the spring of 2020. But the National Center for Health Statistics decided that they were going to do a survey in real time to see what was happening to health insurance coverage as COVID progressed, because it seemed so obvious that what was going to happen is a catastrophe. And as you can see here in this picture, really nothing happened to health insurance coverage. Health insurance coverage in the United States remained virtually flat over the entire COVID period. In fact, the Congressional Budget Office, which is the main budget estimating office of the government, it's allied with Congress, not with the presidency, so a little more independent. They estimated that the number of people without health insurance in the United States might increase to as many as 31 million in 2020, but that group would really include most of the 30 million who were already uninsured in the absence of the pandemic, plus not more than 1 million people on a base of 320 who might lose coverage on account of the pandemic. And even that did not happen. So why? Why did the dog not bark in the night? Why did coverage not fall apart when COVID happened in the US? What can we infer from this? Well, the first reason for this is that the job losses that I showed you, and now I'm showing you data from New York, which was perhaps the most hard hit, certainly the most hard hit in the first wave of the pandemic, were not evenly spread across the entire population. And we have some data on what kinds of occupations are remote work capable, and I'm sure that the same analyses have been done in England. Some people have jobs that they can do from home, and many people have jobs that they cannot do from home. Here you can see that low-wage workers are much less likely to have jobs that they can do from home, and we're much more likely to lose employment because of COVID, as were those with less education. So the job losses in the US were concentrated, for example, in the hospitality business and tourism-related businesses and all these service occupations. Well, the thing about those jobs is that they were always terrible jobs, and typically they didn't have health insurance in the beginning to begin with. So the people who were losing jobs were not the people with health insurance. They were people who had never had health insurance, and so they did not add to the uninsured. Not a happy story, but not the catastrophe that people had anticipated. The second thing, a more happy story, is that in fact there were lots of places post the Affordable Care Act for people to go if they did lose their coverage because of COVID. You can see that in the states that had expanded their Medicaid programs, about 3/4, can you see my pointer here? About 3/4 of the population was eligible for Medicaid, which is a program that does not require any payment of premiums. There is no cost sharing. So that program is one that people can sign up to at any time. And a very substantial proportion of the people who lost coverage during COVID in the expansion states were eligible for this Medicaid coverage, and a further about, I don't know how big that block is, but maybe a sixth of them were eligible for heavily subsidized coverage in the marketplaces. In the non-expansion states, the ones that had chosen not to expand their Medicaid program to all low-income people, still about a third of the population was eligible for Medicaid and another third for tax credits. But there was about nearly a third of the population, a quarter of the population, who were not eligible for either of these things. So overall, about 7% of job losers were ineligible for public coverage or new coverage because they either had incomes that were too high to qualify for the various subsidies, or they were themselves non-citizens. They were just ineligible in the first place. And about 7% of all job losers across the United States were ineligible because the state had not expanded Medicaid. But adding those up, about 85% of all job losers were eligible because of the Affordable Care Act for coverage in one way or another. And indeed, you can see that in all states, enrollment in the program, in the public program that serves low-income people, increased substantially over this period. And in the marketplaces, we have less granular data. The marketplace enrollment had been declining over time. That's the Trump administration really cut back on a lot of things in the program, so you can see it declining, but then it began to tick up again in going into the 2021 enrollment season in the fall of 2020 as people who had lost their coverage enrolled in the marketplaces. Since the Biden administration has come into office, they've actually expanded those marketplace, they've enriched the marketplace premium benefits, and they've expanded enrollment, and another 1 million people have actually signed up for the marketplaces since then. So overall, this is the story of kind of what happened with COVID, which is that coverage was not the piece of the puzzle that actually turned out to be a problem because of COVID. Now, I say that very carefully, because of COVID, because there are still nearly 30 million uninsured people in the United States. Overall, there are some 10% of the population who don't have coverage, about 2 million of them because their state did not expand Medicaid, and the vast majority because coverage is just too costly for them. They cannot afford, or they do not wish to purchase, depending on how you see it, coverage at the prices that are available to them. There is a chunk of people who are undocumented who don't have coverage, and there are some people with other reasons for not having coverage, but they are few and far between. I think to get a sense of kind of where the US is in this post-COVID, post-ACA period, it's actually best to look at this on a state-by-state basis. And you can see that there is a constellation of states not sort of surrounding Ontario and Quebec. I'm originally Canadian, so the states that border on Ontario and Quebec, right up here in the Northeast, New York, Vermont, Massachusetts, Pennsylvania, Michigan, where the uninsurance rates are below 7%. But I think the key state here to look at is Massachusetts. You can't see it in this picture, but the uninsurance rate in Massachusetts is on the order of about 3%, almost all of which are people who are not eligible for public coverage because of citizenship. So what this suggests is that the structure of coverage under the Affordable Care Act can, with sufficient state energy, attention, and so on, provide very close to universal coverage for the population, and that coverage can be sustained even through a catastrophe as terrible as COVID. Overall, just looking at the coverage situation in the United States, what COVID has taught us, I think a lot of people had either feared or hoped that what COVID would do is eliminate job-based coverage, which lots and lots of people have criticized for many decades, that tying health insurance to jobs is just a bad idea. There were a lot of people who, with that idea in mind, thought, well, COVID is going to be the moment that we actually move away from job-based coverage to something else. That does not look like it's happening. Job-based coverage seems to have held up quite well despite COVID. It looks like the safety net that was constructed by the Affordable Care Act acted in effect like a safety net, did catch people, especially in those states that had expanded. And what that leaves us with is that in many respects, both in terms of the aggregate cost of the US healthcare system and in terms of the cost of coverage for individuals, it is actually the cost of healthcare at this moment, rather than access to coverage on any terms, that is the biggest problem. I'm going to go on to talk about payment structure, but if anybody had questions about coverage, I could actually talk about that more now.
If I can just ask a question, when you say job-based coverage, is there any kind of minimum wage, or can any job get coverage? I mean,
so there is so the U.S. has a minimum wage. There's lots of debates about what that minimum wage ought to be. But separate from the minimum wage, employers of their own volition, there is no requirement that they provide this coverage, offer health insurance as a benefit to employees. And the vast majority of employees who are offered this benefit take it. The employer of their own volition, employers put in about 3/4 to 80% of the cost of that coverage. They contribute directly, and individual employees have to pay the remaining share of the coverage if they choose to participate in it. That would also be coverage that would cover their families. Under the Affordable Care Act, the coverage would include their children up to through the age of 25. And that is where most Americans get their health insurance, is through this employer-based system that is very weakly regulated, more regulated since the Affordable Care Act, but overall not a highly regulated system. Some of these employers buy for-profit health insurance. Some of them effectively insure their employees on their own, what are called self-insured firms. Some of them participate in capitation arrangements. The variants are endless.
And the other big question that Nicola Masks has posed is, what happens to job-based coverage when you retire?
So most people retire between ages 62 and 65. At 65, you begin to be eligible for the Medicare program. So anyone at 65 or older is publicly insured. They often have a job-based retirement health insurance program that may wrap around Medicare and provide them with additional benefits, but their primary insurance is Medicare insurance. For people who retire prior to age 65, they can purchase coverage as of 2014 on the Affordable Care Act marketplaces. They are eligible for that coverage. They're eligible for subsidies for that coverage if their income is low. The coverage is quite heavily regulated and older people pay more than younger people, but the differential is highly regulated. So many people will be getting coverage that they purchase on their own through the marketplaces. And then people who come from union jobs or some other relatively generous jobs might actually get retirement insurance through their employers. So employers can also offer retiree insurance plans so that people, which they might do in order to encourage people to retire and not keep working just to keep the health insurance. So one of the perverse things about the Affordable Care Act is that it led to some decline in labor force participation because there was a group of people older people who kept working simply in order to maintain their health insurance.
Okay, so thank you. I think that those are the two questions that have come up, and I think
Okay.
carry on
As
to the
I
next.
said, it's remarkably complicated and bizarre to make sense of. So let me talk next about payment structure and how the US system of payment of healthcare providers fared under COVID. So this is data that we built our own simulation model to see who was going to actually be paying the bills for COVID treatment in US hospitals. And what you can see here is that most of the bills for COVID treatment would be expected to be paid, and in fact were paid by public insurance programs, especially the inpatient care would be paid almost entirely by the public insurance programs, with a piece of it being paid by private insurance and a very small number of people who are uninsured. And the reason for that is that actually most uninsured people are relatively young adults. Now that since the Affordable Care Act, everybody is eligible to buy health insurance, health status is no longer a barrier to it. It's kind of what the group that are often called the young invincibles, young healthy people who think that they don't need health insurance. They're often the ones who go without it. And even if they got COVID, they were typically not that sick, so they were not incurring the big bills. Because the epidemiology of COVID, which had its worst effects on seniors, the insurance gaps were not as serious a problem. And as I said before, the government eventually did step in to ensure reimbursement for those who were uninsured. So the first few articles that I wrote about COVID back in March, the ones that were the most wrong of everything I've ever written in my life, were about how the U.S. healthcare system would be overwhelmed with COVID cases, expenditures would go through the roof, and we had to worry about covering the uninsured. And of course, none of that happened. The uninsured were not the people who got COVID, and expenses did not go through the roof. In fact, 2020 is probably going to go down in history as the year that U.S. healthcare expenditures fell, actually declined in real terms rather than increasing. And of course, the reason for that, maybe not of course, but the reason for that is elective procedures and hospital admissions were canceled all the way through the spring of 2020, and they remained at well below historic patterns all the way through December of 2020, even into this year. So you can see that big bump of lower cases, a decline in admissions back in April, and it comes back, but it does not come back all the way. So what does this mean for the healthcare system? So another complexity of the US healthcare system is that there are many different ways that doctors, hospitals, other providers are paid. And a lot of attention goes to a lot of those different elaborate, complicated ways. But the truth of the matter is the vast majority of services in the United States healthcare system are paid on an activity-based, fee-for-service basis. So doctor sees patient, doctor bills insurance company, doctor receives pay. Dentist sees patient, dentist bills insurance company, or perhaps the patient, dentist is paid. In hospitals are paid case rates that are diagnosis-based, but they are still activity-based. If you get a payment when a patient is admitted to hospital, if the patient is not admitted to the hospital, you don't get paid. There are some exceptions to this. In California, particularly, there are these staff model HMOs, health maintenance organizations, where most of the providers are paid capitated rates. Insurers throughout the country are paid capitated amounts. They're paid a flat amount every month, whether people use services or not. And in one state, the state of Maryland, hospitals are under a global budget and they just receive a single budget, regardless of whether there is activity or not. But in the rest of the country, it is a completely activity-based healthcare system. The consequence of that, of course, in the COVID time, is that total health spending fell quite dramatically in the second quarter, particularly of 2020. It began to fall in the first quarter, and then it really fell afterwards. And it didn't really rise back up again, even through the fourth quarter of 2020. There was a big decline in US healthcare spending overall, and a very big decline in professional spending. So big decline in the incomes of doctors and dentists and healthcare professionals more broadly. the hit for hospitals was particularly dramatic, and it was particularly dramatic because of the kinds of procedures that were no longer being done. So this is a study done by some colleagues on what happened to more discretionary and less discretionary procedures through the COVID time. And you can see here that even during COVID, patients with cellulitis, renal failure, gastrointestinal hemorrhage, they were getting treated at almost the same rate as pre-COVID. There was really no big decline in these non-discretionary procedures. But on the other hand, angioplasty, lower extremity hip knee replacements, more discretionary procedures declined in volume precipitously. Those were the procedures that actually went away. Now, the thing about those procedures is they went away, and they are the ones that are the most lucrative for the hospitals and for the healthcare professionals in the US system. So this is actually a calculator for how much money you're going to lose because you have to give up your elective procedure group. And this was a problem for all hospitals, but it was particularly a problem for hospitals that were kind of on the financial edge, who don't have much money to begin with, because these are really the only sources of true profit in the system. These are the only places where you're actually contributing to your fixed costs in a big way. But the canceled surgeries were a really significant challenge for the healthcare system because there was no way within the system to pay for them. So the federal government, in its trying to think about how to respond to COVID, the general approach to responding to COVID, and I don't think the US was particularly unusual in this, was to think about COVID in terms of its effect on the labor market and to try and replace revenue across the labor market, not only in the healthcare system, but everywhere where revenue was down. So in March, one of the very first things Congress did is it passed a bill called the CARES Act, which provided relief payments. And some of those relief payments were dispersed to healthcare providers. They weren't as much as the hospital losses, but they did disperse some of that money to healthcare providers. Now the question is, in this incredibly fragmented, complicated system, where no single payer is responsible for most of the money flowing through the system, how do you figure out how much relief payment to give to each healthcare provider? Their initial instinct was to provide the relief payments based on the payments that had been made by the federal Medicare program, which is the program that serves the elderly. But of course, that left out large segments of the population large segments of the provider population who didn't serve elderly patients at all. For example, the initial tranche of payments provided no money to pediatricians because pediatricians don't serve Medicare patients, and no money to children's hospitals because those hospitals do not serve Medicare patients. And moreover, some of the large hospitals that have lots of privately insured patients were not able, they said, well, look, we have all these workers and only a portion of our money is coming from Medicare. This is not enough for us. So instead of providing federal relief payments based only on Medicare spending, it turns out that every hospital has to provide to the federal government information on all of its revenues, and they began to disperse the money based on the hospital's prior year revenues, not only on their Medicare revenues, but on their prior year revenues. So I saw that Ruth Waitsberg is on the call, and I actually had put this slide in already. A group of us had actually just got a paper forthcoming in the Milbank Quarterly comparing how different healthcare systems coped with the decline, compensating providers for the decline in service utilization that happened during COVID. And as always in all international comparisons, the US is an outlier in the way that it did it. It tried to protect the providers, but in a way that, as I'm going to show you, it turned out to be problematic. Now, the consequence of all this activity-based payment, is that it actually put the hospitals in a very funny position. Because they only earned money if they were providing services, they were often at loggerheads with the public health establishment. The public health establishment wanted everything to close down, to tell everybody to go home and stay home. And the hospitals were busy telling patients, no, you can come in. Things are not as bad as you think. We have plenty of capacity. And there were actually stories in Texas of hospitals saying, we don't need to close down our elective surgeries. We can continue to do elective procedures. We're okay, even if COVID is raging. You would have thought that the healthcare system might be aligned with public health, but the nature of activity-based payment really was ill-suited to this. It really set up this conflict between the system and public health, and created perverse incentives. Now, activity-based payment has a lot of pluses to it, and I don't really know where we should go with it here. Does the fact that it doesn't work very well in COVID make activity-based payment a bad idea? And that kind of depends on whether you think COVID is a 1 in 100 years event or a 1 in 2, 5, 10-year event, and I don't know the answer to that question. But in general, the reliance on activity-based payment was a real challenge for many healthcare providers in the US through COVID. I see that there's a question here. Right, so we'll talk about that in a minute. I'm going to talk about payment levels. So because of the way the CARES Act works, some providers actually came out well ahead and other providers did not do well at all. And that takes me to sort of my next topic, which is the topic of payment levels. And this one, I think, begins to encroach on areas where other healthcare systems have some of the same problems. So up until now, I've been talking about things that I think are very uniquely American, but here I want to talk about some challenges that I think often face systems more broadly. So hospitals from an economic perspective are very challenging. They have very high fixed costs and relatively low marginal costs. So we usually pay hospitals one way or another, however we may pay them, at some average cost, which tries to compensate them in part for their fixed costs as they do activities. When you do activity-based payment, you're basically bundling the fixed cost with the marginal cost. In the US, we do a variety of different activity-based payment levels, DRGs, which are the prospective case-based payment. And there's been a big move towards what are called bundled payments, which are bigger cases. But the key is that the payment rates for these different bundles in most places in the country vary dramatically across payers. And I mean dramatically, not only between public and private payers, but also among private payers. So this is data on how much would a hospital collect for a patient who was diagnosed with COVID. And what you can see here is that Medicare pays about $12,000 for a COVID-like admission. The DRG code that is used with COVID. Medicaid payments rates vary by state, but they come in relatively close to Medicare. But then you see that blue bar, that is the range of payment rates that have been identified for private payers. I think it's actually, I think I've actually cleaned off the outliers here. So it's somewhere between twice as much as Medicare pays and 3 times as much as Medicare pays for the same patient. In fact, a younger patient, a healthier patient, typically, if they are privately insured. And there's this enormous range among private insurers. I should say that the same private insurer will pay very different rates to different hospitals, and the same hospital will receive very different rates from different private payers. So it's a complete mishmash of rates that would be received. The same hospital might receive for the same procedure 20 different levels of payment. Now, for some time, American health analysts have looked at graphs that look like this. This is the ratio of Medicare. The gold line here is the ratio of Medicare payments to average hospital costs. The green line is the ratio of Medicaid payments to average hospital costs. And the purple line, or whatever color that is the ratio of private payments to average hospital costs. And hospital executives would come to Congress every year and they would say, you know, every time you try to cut payments for Medicare, what happens is we wind up charging more to the private insurers. So what we're doing is effectively subsidizing the Medicare and Medicaid programs by charging higher rates to private insurers. This is a famous paper about this. Many policymakers believe that when Medicare constrains its payment rates for hospital inpatient care, private insurers end up paying higher rates as a result. This is what's called cost shifting. And really, this is a question in an economic sense about who bears the burden of fixed costs and how the negotiations between hospitals and insurers play out. Sort of the question of how much does it actually cost to run a hospital. So we've had this conversation for a long time, but when you actually start to look at the data, it turns out not to make a whole lot of sense. And here's why. This is New York State hospitals, and this is the private share of discharges in these hospitals. And you can see here that the 25th percentile of hospitals, only 18% of their discharges are private. Almost all of their discharges are Medicare or Medicaid paid at those low rates. And by contrast, the 75th percentile hospital has about a third of its discharges private, so much more. And my hospital, the hospital where I work at NYU, is this red bar over here. Over 60% of our discharges are private discharges. So this idea of cost shifting, which is that within a hospital, money is moving around between private and public payers, doesn't really conform with these facts. The money is not moving from my hospital to this hospital. It might be moving around within this hospital, but they don't have much money to move. And so this sort of casts some doubt on the cost shifting hypothesis. But watch what happens. Government responds to COVID by passing this provider relief fund and dispersing money based on prior year's revenue. This is what happens to the CARES Act money that goes forward to different hospitals and providers. But here's how it falls out between high private insurance and low private insurance hospitals. The hospitals that were already doing very well, the hospitals that had a lot of private insurance, they got considerably more money per hospital than did the hospitals with the lowest share of private insurance revenue, because the payments were based on the prior year's expenditures. And what did that mean? Well, my hospital, as I showed you, is up here on the left. The hospital in New York that was hit the hardest because of COVID was a hospital called Elmhurst Hospital. You can see that dark pink area there. That's the worst COVID cases, the highest number of COVID cases in the city. And you can see that they had only 12% private patients. So when the government dispersed all that money, they got very little of it. And the hospital I work at got an awful lot. It actually really brought home this reality that had existed well before COVID, that hospitals are receiving extremely different amounts of revenue through the system. Hospitals vary considerably in their payer mix, and the payers vary in their payment levels. So even in ordinary times, how does a hospital that only has 12% of its money coming from private insurers survive? And in fact, the New York Times published this devastating critique saying, whether you survive the virus or not depends on what hospital admits you. If you are stuck at a hospital that has very few resources, which means fewer nurses, less protective equipment, less ability to clean the beds out from one night to the next, and so on, you are much more likely to succumb to COVID. And that brings me to the last of the things that COVID brought forth, so that I have some time to take some questions, which is disparities. It's very clear that COVID has affected Black and brown people and poor people much more than other groups. Now, why is that? Some of it is the initial exposure. Some of it is the crowded households and subsequent exposure. We're seeing a lot of that. A great deal of the effect is living conditions, less ability to cope with the lockdown. This is from Daniel Defoe. This is not a new problem. This was true in the plague year in London. Poor people have to get out and get their work done, and that happens with COVID or with no COVID. And it certainly was true in New York. We've just finished some analysis looking at influenza and COVID. So we're looking at a sociodemographically similar population. These are all Medicaid patients. And we're looking at the hospitalization rates in different epidemics. The first two pictures are the 2016-2017 flu season, then the 2017-2018 flu season, and then the COVID season. And you can see that the geographic patterns of admissions are very similar across all of these. So these disparities that generate death and morbidity and mortality from infectious disease, they are nothing new. They're the same ones that we saw, that we have seen historically, but COVID really brought them very much to light in the US healthcare system. So overall coverage, I think, the immediate problem has largely solved it, but maybe the recession is going to reignite it. We'll see. In terms of forms of payment, this concern about activity-based financing and its compatibility with public health. The level of payment, COVID-19 really shining a light on the haves and have-nots. And then finally, the continuing disparities in health outcomes, which were really brought to light in COVID because of comorbidities and crowding and social determinants, but also quite possibly because of those differences in the level of payment in the hospitals that serve richer and poorer parts of the country, so and the city. So let me stop there and take your questions.
Well, can I just, the one that's come up, which goes directly from that, were treatments such as ventilators and newly studied ones, such as the drugs, such as remdesivir, etc. Were these given disproportionately to the insured patients in their admissions and more costly in treatment ration for Medicaid?
Right. So it's not that within a hospital, what we know is that within a hospital, patients are treated the same. There isn't reason that in general, most studies find that whether you're a Medicaid patient or a Medicare patient or a privately insured patient, if you go to the hospital where I work at Langone, they will all be treated the same. The problem is that poor people wind up in hospitals that only treat poor people. So all the payments they ever receive are low payments. And they have fewer resources, fewer ventilators, fewer nurses. As a general matter, even if a rich person showed up at that hospital, they would receive this less good care or less well-resourced care, because it's the hospital and not the patient that determines really what care people receive.
And the other big question really relates to the fact of, is the United States being dragged slowly into a more equitable healthcare service provision? And the wording that I think the wording that Steve Herman used was that comprehensive federally funded health service.
I think it is in the next 4 years. I would be very surprised if we're going to go to a comprehensive federally funded health service. I think that what we will see is continued efforts to plug holes, the gaps that already exist. And the Biden administration has already taken several steps to plug some obvious gaps in the system. I do think that both because of COVID and because of other research developments, there will be more attention paid to these issues of prices, to the issues of payment, and how much different insurers are paying to different hospitals, to different healthcare providers. The same thing is true on the physician side, or even more true on in the outpatient diagnostic and surgical centers, which tend to be more likely to be for-profit, more discretionary. These differences in payments have really come up to the surface in a lot of health policy discussion. And that's perhaps the direction that there will be the most radical change. If there is going to be radical change in the next decade, it will probably be in the direction of trying to rationalize or reduce some of those higher prices in an effort to create some more equity in the system, but also to bring the cost down overall.
I see that Stanley Rice has put in the point that the rich hospitals are going to be more likely to participate in clinical trials, so that affects the quality of treatment. Does that apply in the United States as well?
Yeah. So of course it does. The richer hospitals have a much bigger research component to them. They're more likely to be academic health centers associated with universities and medical schools. And they are more likely to get engaged in clinical trials. And the populations who frequent those hospitals are often populations who are more willing to enter into the clinical trials. So it's a self-fulfilling prophecy. These are hospitals that do it. People trust the doctors there. The people who go to those hospitals are more educated, more interested in being involved, and they have more resources to do things like send email messages encouraging people to join the clinical trial. And when you have resources, everything is much easier.
There's an interesting question, though. 8 years ago, Sir Bruce Keogh looked at the question of what constitutes a failing hospital. And his conclusion is a failing hospital in the UK, and the failing hospital is the one that doesn't have research activity. So there's a kind of circle.
Right, the research activity, well, in some sense, it's the same thing, right? The research activities are going to the hospitals that are successful. They have research activities. Whether you could, so in New York City, I don't know about the rest of the country, very often medical schools will send their students to the poor hospitals to actually do rotations there as well, in the time-honored tradition of that. And they will do some research studies, but it's just harder when there are fewer people around and less flexibility in the system.
The one person who has bridged the American and the UK systems is Simon Stevens.
Yes.
And there have been paeans of praise for his contribution to British healthcare system. And some people have been a bit surprised about this, because the part that appears to have been neglected is primary care, family practice, general practice, however which to term this. What role has primary care and family medicine played in the United States during the COVID-19 period?
That's a very interesting question. So interestingly, and I don't know whether it's true in England also, I should actually look, it would be very interesting. In the past 10 years, there's been a pretty consistent decline in the use of primary care in the US. No one is completely sure why. Part of it may be there has been a new industry of, what are they called? Mini clinics that are usually run by a for-profit or a corporation, sometimes a not-for-profit corporation. These are urgent care clinics. They're usually open from 7 in the morning till 10 or 11 at night. You don't need an appointment. You can just walk in. And that has siphoned off a bunch of care from primary care. There's also much more virtual. There are also telemedicine doctors who will provide people with primary care. So primary care had been in a bit of a funny place, with a lot of people, enthusiastic about it, and at the same time, a decline in the actual utilization of it. When COVID happened, primary care practitioners who were in medical groups, and a lot of American primary care practitioners are now parts of large medical groups, they were able to transition pretty quickly to telehealth and to provide a lot of care online. The ones who were more in independent practice, and there are still some of those, they had a much harder time, of course, in transitioning to telehealth platforms, and they saw a much bigger decline in their revenue streams, and a lot of concern about the long-term survival of those practices as they saw their revenues fall off. We'll see how primary care comes back post-COVID, because the big growth in telehealth, my own sense is that is probably not a good thing for the long-term survival of the primary care world.
And the other issue that relates, that's asked in the UK, is the question about care homes. The question about the huge fatality rate in care homes, and how has that panned out in the United States?
So that, I think, has been somebody will have to do a comparative study. What we call here the nursing homes were very hard hit and have caused the downfall of many politicians for failing to protect the nursing homes. It was even worse, I believe, in Canada. And the research suggests that a big problem, and I wonder if it's also true there, has been the personnel who travel among the homes. So so there are a group of people, physical therapists, occupational therapists, some clinicians, who go from one home to another, and apparently they were actually the ones who were taking COVID from one place to the next. But here in New York State, where I live, there has been a whole scandal about the governor and the nursing homes. He had, when the pandemic hit New York very hard, he had actually required the homes to accept COVID patients when they were discharged from hospital. And of course, they were at that point being discharged, so it's not clear whether they were still going to be transmitting virus, but that was, and no one really knows what happened, of course. But he has been very much tarred with this scandal.
And was the funding from that for those people in care homes coming from Medicare or Medicaid, or was that?
So they were getting, because again, they are sort of activity-based financed in the sense that people pay by the day or the week or the month. The care homes remained full. People had nowhere to go. They were kind of locked into the care homes. And so they kept getting their funding as they had before.
Right, so it didn't make any difference to them from.
There was some effort to provide them with extra money to buy protective equipment, but that was relatively small amounts of money.
Yeah, there is another question that's just come up. Fiona, what, if any major health policy changes do you think the Biden administration will attempt to introduce?
Well, so the Biden administration has already passed one set of changes around making the premiums for people who need to buy health insurance on their own in those marketplaces lower. So it's a temporary fix, but they have lowered it, and that's part of the reason that more people have signed up. Now, it's important to know that the Biden administration has no margin of error in the Senate. There are 50 Democratic senators exactly, and in the United States, senators vote their own conscience all the time. There is no requirement that you vote with your party. And many senators do not vote with their party. So the two most conservative of the Democratic senators, Kristen Sinema from Arizona and Joe Manchin from West Virginia, have signaled pretty clearly that they are not excited about transformative healthcare policy. There is likely to be policy regulating the price of pharmaceuticals in some way, maybe. I shouldn't say likely. There may be policy regulating the price of pharmaceuticals. I don't think there's going to be a lot more than that. There may be some efforts to expand coverage to those unfortunate people living in the states that did not participate in the Medicaid expansion, who are really in a terrible place.
Right. Ruth Weinsberg has asked, who covers routine immunizations usually and COVID-19 vaccines?
So insurers are required to cover routine immunizations. Public health departments will cover them for people who are not insured, and they are also required to cover COVID-19 vaccines, and public health departments will pay for them for people who are not insured. There has been, as far as I have heard, no problems in paying for vaccine. That has not been a problem.
So what other problems that they've had other than money with regard to vaccines? Why is the United States not as vaccinated? Is it something to do with the health service structure?
No, I mean, two things. I think one is because we didn't approve AstraZeneca. So Pfizer came along a little bit later. So part of this is just the timing of Pfizer coming along a couple of months later, getting the approvals about a month later. And so for a while, there was simply not enough vaccine for people who wanted to be vaccinated. It wasn't a money issue, but there just wasn't, the shipments of vaccine were not sufficient. At this point, the US is very close, maybe second or third Israel is number one. There are some small countries in there, then the UK. The US is well above Germany and many other countries in terms of the proportion of the population that's been vaccinated. The challenge now is there are two large groups in the US who are very hesitant about the vaccine. One is members of minority groups who have had a long history of maltreatment by the healthcare system and are simply mistrustful of it. And if you look at the history, it's not surprising that they are, but it's going to take some work to get them vaccinated. And the second group are people who are supporters of the former President Trump and who believe a huge amount of misinformation that has been floating around on the web, and believe that, Bill Gates has put, what is it, that there are chips inside the vaccine that get into your body and transmit information back to Bill Gates, or that the vaccine is going to make women infertile, or that you can pass it to people. There was just a story about how vaccinated people could actually transmit the vaccine through their skin to children. There's a lot of misinformation. I'd just be polite about it. And so there are parts of the country where there's lots of vaccine sitting around and no one is willing to take it. They're now giving you a case of beer if you'll get vaccinated.
Well, on that variation of traditional systems. There was a stage when heads of departments in medical schools and universities in the UK were given a case of wine as part of their salary. So that's not as extraordinary a thought as you're making out. But I think that we've now taken up a huge amount of your time in the effort that you put into preparing this for us, as well as the way you've explained a complex system and made it sound in its own way much simpler, much simpler for those naive Europeans who try to follow it. But seriously, thank you very much for that.
Thank you for the invitation, and I look forward to meeting some of you in person someday.
I hope so too. Thank you.
Bye-bye.